Welcome back, Module 3, Neurology. Hey, now that you have the anatomical understanding and you understand how the upper cervical spine moves biomechanically, we're going to add the last piece to the puzzle, neurology. And what I'm going to do, I'm going to walk you through the complete neurological cascade of how a serious head and neck injury is going to cause a plethora of spinal problems. Now, to start things off, I just want to remind you that the science is always changing when considering the human body. It's also improving, but I just want to let you know that the science that I'll be sharing with you today is current and up to date. So let's dive in here. Of course, it starts with an upper cervical head and neck injury. Now, it could be from sports growing up, football, soccer, basketball, wrestling, a gymnast falling on their head. It could be a fighter taking a blow to the head. It could be any form of concussion, falling off a bike, falling off a roof, hitting your head on a cabinet, any sort of whiplash injury from a car crash. Pretty much anything that's going to quickly jolt the head and the neck. So here's a complete overview. What I'm going to do is I'm going to break down each step, and I'll promise to keep it simple for you. Simple and easy to understand. Okay, now when you injure the head and the neck, it's going to do a couple things immediately. One, it's going to tear loose and stretch the connective tissue that basically holds the head center over the neck. It's mainly going to be the upper cervical ligaments, which we already discussed in detail. Let me go ahead and play this again. But all of you should be able to see this animation. We call this an upper cervical misalignment because the atlas is shifted out of its normal position, causing the head to tilt and then the lower neck to angle underneath it. Now, when this happens, the four primary suboccipital muscles are going to stretch. Now, remember when I said that I was going to save four muscles specifically for the neurology module? Well, here we go. I'm here to tell you that these four sets of muscles right here, 8 in total, are the most sensitive muscles in your entire body. Now, how do we know this? Muscle spindle density. Every single muscle in your body has a certain number of muscle spindle fibers that are going to send information to the brain. Now, the suboccipitals have the highest density of muscle spindles compared to any other muscle group in your body. And as you can see here, starting with obliques capitis inferior, coming in with 242 muscle spindles per gram of muscle tissue. Guys, this is the most sensitive muscle in your entire body. And if you also remember from earlier, this was the muscle I mentioned that can, when it stretches, it can entrap that greater occipital nerve, which is going to cause cervicogenic headaches. So again, very important muscle to pay attention to. Okay, coming in second, obliques capitis superior. We've got 190 spindles per gram. And then third and fourth, rectus capitis posterior major and minor with 98 spindles per gram. And just to do a comparison here, I've included biceps brachii here, 97 total muscle spindles. Now this isn't per gram, this is total. And the bicep is much larger and weighs a lot more than all the suboccipitals combined. So when these muscles stretch, what's going to happen is that they're going to change length, which is going to cause the mechanoreceptors to activate. And then think of mechanoreceptors as being the ones who sense that the muscle has stretched, changed length, and now it's got to communicate that to the brain. Now, these are very, very sensitive when quick motion occurs within the muscle. Lastly, know that 82% of all mechanoreceptors in your body are located in the upper cervical muscles and ligaments. Just incredible. Okay, now that the mechanoreceptors are stimulated, it's going to send that neurological signal up through lamina 7 of the spinal cord. And not to get into too much detail, just know that the spinal cord has a total of 10 different sections, or 10 major pathways in which information is sent to and from the brain. Okay, the signal is going to continue up to the cerebellum, the posterior lobe of your brain, which is responsible for controlling equilibrium and balance. Now, as the signal moves up even further, it's going to hit the vestibular nucleus, which is located right in the medulla of the brainstem, right in front of the cerebellum, highly responsible for eye movement, controlling the eye muscles, right tandem with the cerebellum. They're going to work right side by side. But ultimately, the both of them are going to keep you upright and posturally balanced. Talk about symptoms like eye nystagmus, dizziness, vertigo, people falling off balance. Just know it's all related. Okay, so now that the signals reach the vestibular nucleus, it's going to tell the spinal postural muscles on one side of the body to contract and tighten. Now, hopefully everyone can see this animation here, but the postural muscles that I'm referring to are your erectors, rotators, multifidi, your QL, quadratus lumborum. And so just keep in mind, those are the extensor posture muscles. Okay, oh, it's the rat study. Okay, now I'm not going to go into the scoliosis rabbit hole here, but hear me out real quick. There was a study done where researchers took a bunch of rats and purposely damaged their vestibular nucleus. Then they hooked them up to an EMG machine to specifically monitor their muscle tone. And at the end of the study, they imaged the rats, took some x-rays, and found that 25% of them developed a significant spinal scoliosis. And get this, on the convex side of the scoliosis, all of them had a hypertonic spastic musculature on that same side. And they knew that because they had them hooked up to the EMG. Now that's all I'm going to say about that. And yes, I understand they're just rats, but it's still another interesting data point to see how something at the level of the neck and the brainstem is going to affect the rest of the spine. Okay, back onto human muscle imbalances. Now, once the posture muscles contract unilaterally along the spine, the body is going to compensate by leaning to one side or the other. Notice the green line in this picture here. The line is at the center of her feet and goes all the way up. Now, normally, the line is going to pass through the episternal notch if the spine is centered, of course. Now, sometimes it'll also run right through the nose, depending on if the head is tilting or not. But with her, as you can see, her spine is shifted off center. You can see she's leaning over to the left. Now, I can only imagine how much more pressure is being placed on her lumbar discs. Because think of it like this. The longer the posture is shifted away from center, the more pressure and compression will be placed on the discs. And it's only a matter of time before the discs become less stable and begin to bulge, especially the lumbar discs, because they have the weight of the entire torso and upper body compressing down on them. Most commonly L4, L5, S1. As massage therapists, I'm sure that you see a lot of acute disc cases, whether it's sciatica, so you know what I'm talking about here. Okay, now as the annular fibers are stretched from the spinal compression or some sort of acute injury, this is when you'll most likely begin to notice pain or symptoms. And of course, as therapists, as you know, all pain is a protective mechanism of your body designed to stop you from moving. Why? To protect the spinal cord and nerves exiting the spinal cord, making sure they don't get damaged. But regardless, if you have symptoms or not, the brain knows exactly what's going on. So a small disc bulge, as in this case here, may just cause some local back pain, But if the disc is severely bulging into the sciatic nerve, yes, this is when you will see the sciatica, the pain, tingling, and numbness going down throughout the leg and sometimes even into the foot. I was speaking with a patient just a few weeks ago that came in from sciatica, from bending over to tie her shoe, thinking that caused the sciatica. And although sure, this was the tipping point, the problem wasn't that she just bent over and to tie her shoe. The problem was that she had lost her spinal integrity over the years, and her spine was getting weaker and weaker until one day, one subtle movement, just simple as bending over, was the final straw, like that. Boom, sciatica. Now, when the disc is initially injured, the first thing the brain will do to heal it is coordinate the delivery of protein, water, red blood cells to the injured area, which we call inflammation. So now the area is getting inflamed, which could make it feel stiffer, could make it hurt more, could make you want more adjustments, massage, more stretching, a cortisone injection, pills, anti-inflammatories, pretty much anything to reduce the inflammation. Now, if there's one concept that you leave here with, please understand what I'm about to tell you. If you don't fix what's wrong structurally, then at a certain point in time, your brain says, okay, this inflammation is not strong enough. There's not enough stability. We've got to do something extreme here because we are losing the health of this disc. So the last thing the brain will do is purposely coordinate the stealing of calcium from unimportant bones in your body, most commonly the radius and ulna. But it's going to do this and drag this calcium through the spine, dumping it at the injured disc. Now the goal here is to try and concrete this weak area, giving it maximum stability. Now after this happens, it's very common to see two separate diagnoses. The first is going to be osteopenia, osteoporosis in the bones that the area that the disc was injured, right, where it stole calcium from. And it's commonly going to be the arm bones from my perspective, what I've seen. And then the second diagnosis we'll usually see is osteoarthritis and bone spurs in the spine at the level of the injured disc, when all that really happened was that the calcium simply moved from one area of less importance to one area of more importance, right? Moved from the arm to the spine, from the leg to the spine. Now, I do want to say one more thing. If your patients do have bone spurs, osteoarthritis, please don't tell them that it was caused by getting older. I know several old folk that don't have any bone spurs in their spine, no osteoarthritis, nothing, healthy spine. So to say that just simply getting older is what causes osteoarthritis is completely false. And I'm blown away by how many of my patients tell me this is what their doctor told them. Now, the problem here is that the disc isn't getting old. The problem is that the disc is losing its spinal integrity and has become extremely weak from all the additional compression of the spine being shifted off center, right? All the years of the bending, the twisting, the lifting, the sports, weightlifting, car crashes, the driving, the bumps, the bruises, the picking up the children, the picking up the boxes, all of these things we do from birth, high school, and can and will and does, and 100% of people cause the spinal vertebrae to shift out of their normal position, compress these spinal discs. Anyways, that's all I want to say about back pain, spinal discs, and spinal arthritis. Other than that, when the head is shifted off center, moving here to why people develop a shoulder that is higher on one side compared to the other. And sure, there's cases where someone blows out a shoulder and the head and neck is going to adapt to form fit the shoulder injury. But most of the time, you're going to see that the head and neck is out of alignment first. And then once this happens, then the shoulder muscles are going to tighten to adapt. But when this happens, you're going to see an increased risk of rotator cuff injuries, labral tears, impingement, lots of shoulder injuries. And then with the hips as well, very common reason to see people why they have tilted or rotated hips on one side compared to the other. Because when the posture muscles are contracting unilaterally, then the hip flexors, the quads, hamstrings are all going to tighten and change to adapt to the structure of the hip. It's going to be pulling on the iliac crest or the ischial tuberosity. Okay, when the shoulder's weak, the elbow has a lot more stress on it. It's just bound to happen. And you'll see people start to develop the tennis elbow, golfer's elbow, the tendonitis, and this is where you begin to see the repetitive motion injury really starts to take a toll and manifest. And it's the same thing with the knee. When the hip is off, not only is the knee being pulled on a lot harder from all the tight muscles, hip flexors, brex fem, TFL, and the IT band, but it also has a lot more weight the knee has to hold up because the entire posture has shifted over, placing a ton more pressure on the knee. And you want to know why so many people have knee problems? This is why it's extremely important to address the postural weight differential first, because I see a lot of runners get a knee pain for these exact two reasons, whether it's the knee itself or the posture exacerbating the knee problem. Okay, now with all of this, here's the overarching concept. It's an above-down cascade, not ground up. Unless you severely sprain an ankle, break your tibia, blow out a knee, break your foot. Otherwise, the neurological cascade will always support starting with the brain and what's closest to it. And let me tell you, I believed in the whole ground up approach. Bad shoes are going to give you bad knees, bad hip, bad back, and it's just going to manifest from the ground up. But I'm here to tell you, it's not common to see that. Throughout the 6 years of studying this, I asked multiple health professionals this question. Is it above down? Is it ground up? What's going on here? And from what I learned from the chiropractic side, I'll just go ahead and walk you through that real quick, what I did learn. Now, typically, most chiropractors will take pre-x-rays and then post-x-rays down the road to show that they actually made a positive change in the structure of the spine. Now, the only ones that were getting real structural changes to occur in the low back and the hip were the upper cervical chiropractors. And literally, my mentor docs would take an x-ray of the low back before care. They would only work on the neck, and then 6 months into care, they took another x-ray of the low back, and not only was the lumbar spine 40% better, but the hips were also balanced. Now, when I see this, boom, instant light bulb, and I begin to ask the other chiropractors as well, right? The traditional ones that are hammering away on the back, popping away, same adjustment over and over again. And you know what they said? They said they stopped taking post x-rays of the low back because they didn't see the changes. So, although it is nice to have the neurology explaining why this works from the neck down, it's even better to have the data and the images. So, that's all I got for you. That concludes the neurology module. Of course, if you have any questions about the content, the sources, or any specific questions that may arise from certain clinical cases from your end, please don't hesitate to reach out and send me an email, drbert@eliteuc.com.